Dear friends and colleagues, welcome to the second conference of this really successful module. And today the speaker will be Professor Ballabh, who I thank for his precious collaboration. I leave immediately the floor to the chairmen of today, Professor De Vries and Professor Ramenghi. Please, Linda.
Well, thank you very much, Professor Moretti, again. And I'm very happy to announce this second module today, second part of this module about IVH. And I'm sure that the lecture is going to be as exciting as the music we just heard and will give us the same climax at the end. And therefore, it's a really great pleasure to introduce Dr. Praveen Ballabh, who is a professor in neonatology, currently working in the Department of Pediatrics, Albert Einstein College of Medicine, United States of America. And he has got a long-standing interest in IVH, and he's been doing a lot of experimental work. And his aim is really to prevent IVH and also to have some neuroprotective strategies to reduce the effect of IVH on the white matter. Professor Ballabh is serving as an editorial member and reviewer of several international reputed journals, and is also a member of many international affiliations. And he has co-authored many research articles and books related to neonatology and neuroscience. So we are really very grateful that you are giving this talk today. And please, Praveen, go ahead and give your talk. Thank you.
Thank you, Dr. De Vries. I'm really grateful for the generous introduction that you gave, and I feel honored to be part of the webinar and presenting something which we discovered in our lab. So the today's talk is more for the young upcoming neonatologist and scientist. And this is a kind of a story that happened to me. How did I progress? Being a clinician, I don't have any basic science training. And how did I progress from scratch into the depth of molecular biology and neuroscience? And how, like with the help of my wonderful colleagues in my lab, we discovered something very exciting about intraventricular hemorrhage. So as you know that about 1.5% of infants are born low birth weight, and 20% of them develop intraventricular hemorrhage, which mostly initiates in the germinal matrix. And IVH leads to white matter injury and post-hemorrhagic hydrocephalus. And infants, they often present with cerebral palsy, cognitive deficit, mental retardation, and learning disabilities. The picture that you see here is a 24-weeker infant with grade 4 hemorrhage. You can see so much is the destruction in the brain.
Praveen, could you maybe enlarge your screen to full screen?
Yes, I did. I'm sorry.
Okay,
yes.
Fine, thank you.
Yeah, so this is, tells you that IVH is more common in smaller babies at younger gestational age. And this is about the grades of hemorrhage. As you know, like many of you know, that grade 1 hemorrhage is germinal matrix hemorrhage. Hemorrhage that is confined to the germinal matrix. And this is, when ependyma breaks and blood leaks into the ventricle, then it becomes intraventricular hemorrhage, but there is no ventricular dilatation. We say it grade 2, and this is ventricular dilatation, and this is an intraparenchymal hemorrhage. Now, most of the IVH happen in first 3 days. So you see day 1, 50%, day 2, 25%, day 3, 15%. So I was still I'm not 100% sure why IVH is a problem for first 72 hours. After 72 hours of age, infants are a kind of immune to IVH. irrespective of their gestational age, say 23 weeker, 28 weeker, they are very unlikely to get IVH after 72 hours. So my notion is that they get IVH in first 72 hours because there is rapid angiogenesis in the germinal matrix. And when these infants are born, they're exposed to oxygen, and oxygen suppresses angiogenesis. Suppression of angiogenesis means that the vessel becomes less fragile, and angiogenesis imparts them greater fragility. Now, when I was a fellow, neonatal fellow 25 years back at Cornell, I was looking for a picture of germinal matrix. I want to see a picture. How does it look? I could not find one. So this is, this is a pediatric research paper that I published in 2010. This is a picture from there. This is a 17-week fetus. This fetus was delivered at Westchester Medical Center, and we collected the fetus, and this is a coronal section through the caudate nucleus. So this is the caudate nucleus, if you can see my cursor. And this is the cortical plate. Cerebral cortex is not formed. And everything surrounding the ventricle in blue is germinal matrix. And you can see that germinal matrix is more conspicuous on the head of caudate nucleus, and it thins out as you see around the ventricle. And this is all subplate here a little bit, and then white matter. It is good to say intermediate zone because white matter is not yet developed. And germinal matrix consists of neuronal and glial precursor cells. Earlier in the literature, you will see that it says that it mostly glial precursor cells, but that is not true. Neurogenesis continues until the end of pregnancy. Glutamatergic neurogenesis we published can be seen up to 28 weeks of gestation, and intraneuron neurogenesis happens even after birth, and they all happen here in germinal matrix. So this consists of neuronal and glial precursor cells, and it is about 2.5 millimeters thick at an average at 24 weeks, and gradually it disappears. This is a confocal microscopy image, triple labeling. You can see the ventricle, and all green is GFAP showing radial glia. Red is the blood vessel, CD31 staining. A germinal matrix is highly cellular and richly vascular. You can see in HE staining. And you can also see some double-coated DCX positive cells in the germinal matrix. Now, why babies bleed in the germinal matrix? So pathogenesis of intraventricular hemorrhage is attributed to fragility of germinal matrix vasculature and fluctuation in the blood flow. When babies are in utero, 24 weeker, 25 weeker, scarcely they bleed, they don't, because there is no fluctuation in blood flow. Once babies are born, it comes to our NICU. Often we intubate them, place them on CPAP, do IV line, we poke them, they scream, and there is fluctuation in the blood flow. And premature babies, they do not bleed in cerebral cortex or anywhere else. Hemorrhage initiates in the germinal matrix, which means that blood vessels in the germinal matrix, they are fragile. So what causes fluctuation in the blood flow? As I said, fluctuation in the blood pressure. We infuse bicarb, but like I believe that if you give it on pump over 2 hours, it doesn't matter. But if you do push a bicarb, sudden increase in osmolarity can give rise to IVH, high CO2s, low hematocrit, low blood pressure. Babies with pneumothorax in first 72 hours, frequently I see them getting IVH because it increases venous pressure, RDS, and so on. Now, this work was done by Dr. Jeff Perlman in 1980, early on, when he was working in St. Louis children with Joe Volpe. So what he was doing, he was looking at cerebral blood flow by Doppler ultrasound, and he found that two patterns emerged. Here you see that cerebral blood flow velocity and blood pressure is very uniform, very nice wave pattern, and this is stable. Another category he found was that blood flow was more fluctuating. Blood pressure was fluctuating. And he discovered that babies who have fluctuating blood flow, their blood pressure fluctuates, is not uniform pattern. They have more chances of IVH. So out of 28 infants, 21 had fluctuating and they got IVH. So fluctuation in the blood flow in the first hours of life is associated with IVH. Now I will tell you something we did. How did I think, not being a, like a hardcore basic scientist, but just walking in a basic science lab with my kindergarten, and then I started thinking that why babies bleed anywhere? Because there is weakness in one of the component of blood vessel. So blood vessels in the brain, they are unique because they form a blood-brain barrier. And blood-brain barrier consists of, in the pink you see endothelium. Endotheliums are joined by each other by tight junction. Endothelium sits on basal lamina. In gray, you see basal lamina. Embedded inside the basal lamina, you see in green pericytes. And surrounding the pericytes, all in yellow, they are astrocyte and feet. You may not be a basic scientist and you say, my God, never heard about astrocyte and feet. So look at this confocal picture, which I took like 20 years back. These are astrocytes in green. And astrocytes have processes. These processes, they ensheathe the blood vessels. In white, you see a blood vessel. And this is covered with astrocyte and feet. So why does a baby bleed in germinal matrix? So this is how I started thinking, that one of the component of blood-brain barrier, tight junction, pericyte, basal lamina, astrocyte, one of them is weak. So I started looking at each of these components. So first of all, like I started looking in humans, the number of blood vessels, the blood vessel density. And I found that the blood vessel density you see on x-axis is gestational age, y-axis is vessel density. In yellow is germinal matrix, and in orange color here is cortex and white matter. So white matter is the least vascular across all gestational ages, all throughout the life. Most vascular is germinal matrix, and then in between is cerebral cortex. So then I started looking at that tight junction, and I was very excited. I thought one of the tight junction, like claudin or cludin, junction adhesion molecule, one of the three major ones must be weak, must not have been fully expressed, and the vessels they rupture, or cadherin adherin junctions, they must be poorly developed. This was my hypothesis, but I wasn't true. When I started looking at all these molecules by performing Western blot in human tissues, because I worked at Westchester Medical Center for a long time, 15 years, for one of the main reasons was that there was good access of human tissues. We had like a very busy NICU with 50 deaths a year because we resuscitated even 22 weekers. And then, like when I quantified claudin, occluding junction adhesion molecule, the paper is in Pediatric Research in 2005, I could not find any difference in the tight junction molecules between cortex, white matter, and germinal matrix. So expression of all these three molecules were similar in cortical plate, white matter, and germinal matrix. Because babies' vessels are pretty stable in cortex and white matter, there is no hemorrhage. So I concluded that tight junction molecules being similar in cortex, white matter, and germinal matrix, and which means that they are fully expressed in germinal matrix, and they are unlikely to be the cause of fragility of germinal matrix vasculature. Then I started working on astrocyte and feet. This work was done mostly by one of my fellow, Nadine Al-Qari. And so I thought that vessels are not supported with astrocyte and feet. You see, this is a blood vessel supported by androcyte and astrocyte and feet. And astrocyte we can look at histologically by immunohistochemistry using so we use GFA, P antibody, aquaporin 4, and S100 beta. And these are all human tissues. You see here, this is, like you can see the gestational age. This is 27 week. This is, so this column is germinal matrix. On the right, in the middle, all three panels is white matter. And this is cortex. So you can see that all which is blue is the blood vessel. All blue is endothelium. All red is astrocyte and feet. So you can see that red astrocyte and feet beautifully covers the blood vessels. And these are all confocal microscopic images. However, cortex white matter is well covered, but in germinal matrix, look at these vessels. This is not covered with GFAP positive astrocyte and feet. So I thought that astrocyte and feet, they are deficient, but that wasn't true. When I looked at aquaporin 4 is very well expressed. And it is nicely covering the blood vessel. And S100 was not very helpful. It is not a good marker. So we found that GFAP positive astrocyte and feet, they are deficient, but astrocyte feet is there because aquaporin 4 is expressed. Since GFAP, astrocyte and feet were reduced, so this is how I thought, decreased GFAP in astrocyte and feet, it means that astrocyte and feet, they are there, but they are weak, and that might contribute to the fragility of germinal matrix vasculature. Now let us come to more exciting part, pericytes. Now, if you look at this paper, 1997 paper by Lindahl et al., published in Science, and this is a paper from perhaps from Switzerland, or so Lindahl et al., and they took PDGF deficient mouse. PDGF is important for recruitment of pericytes. PDGF deficient mouse, they lack capillary pericyte, and they have aneurysm and bleed in the brain. So this simply tells you that if pericytes are not there, vessels become fragile. They turn into aneurysm. They lose their regular morphology, and they bleed. Now, what happens in diabetes? Diabetes, like a big population of the world has diabetes, and we see in the retina microaneurysm and hemorrhages because high glucose level causes degeneration of pericytes, and the vessels, they form microaneurysm. So pericytes are important to support the vessel. So my question was, is there a lack of pericytes in the germinal matrix vasculature? So this work we did like very extensive work of electron microscopy, immunohistochemical markers. We stained pericytes by Ng2 antibody and PDGF-RB antibody. And I'll show you some very pretty images. So you see here, in red is endothelium. All red is endothelium, all green is pericytes. So here you see that this part of the blood vessel is not covered. This is 17 week. So pericytes are not totally covering the blood vessels in germinal matrix. But, and then even in, this is 21 week, you see that coverage of endothelium by pericytes is inadequate or incomplete. Now look at here, what happens in white matter? White matter, you see that green pericyte is covering the endothelium. Green pericyte is covering the red endothelium. So all red is endothelium, all green is pericyte in all images, and you can see that pericyte totally covers. So here you see that pericyte completely enveloping the endothelium, but in the white matter, but not in the germinal matrix. So we quantified it, and we plotted this graph, which simply shows that pericytes are reduced in germinal matrix. We confirmed our finding by performing electron microscopy, both in human brain and in rabbit pericytes. So here, this is pericyte. You see, this is pericyte, And so pericytes, we quantified them. They are reduced in germinal matrix in human and in rabbit germinal matrix. Now, how pericytes are recruited? Pericytes are recruited by a bunch of growth factors. Transforming growth factor beta differentiates mesenchymal cell into pericytes. And then PDGF, PDGFRB, angiopoietin, sphingosine 1-phosphate, and heparin binding epidermal protein growth factor. These are the growth factor and their ligand. They're critical for recruitment of pericytes. What I'm trying to tell you that initially in angiogenesis, a naked endothelial tube is formed. You see here, a naked endothelial tube, and then mesenchymal cell is coming under the effect of these growth factors, and they are being recruited around the endothelium. And this is how the vessel matures. So germinal matrix vasculature, they are immature. They lack pericytes. So what happens so we did some further studies in human tissues. And if you look at this on a Western blot, here we have 16 week, 17 week, 19 week, their gestational age. Every gestational age has 3 tissues: cortex, white matter, germinal matrix. Cortex, white matter, germinal matrix. You see that band in the germinal matrix is weak, which means that transforming growth factor beta 1 is reduced in the germinal matrix. Whereas PDGFB, angiopoietin, S1P, they were similar in cortex, white matter, germinal matrix. So we concluded that low transforming growth factor beta is pro-angiogenic and might be the cause of low pericytes in the germinal matrix. So this paper was published in a Journal of Neuroscience in 2007, giving the message that pericytes are deficient in germinal matrix vasculature. Now, angiogenesis. How did we discover that there's rapid angiogenesis in the germinal matrix? This was one of the very important work that we did in our lab, discovering that germinal matrix has rapid angiogenesis. But first of all, why would you think that germinal matrix has rapid angiogenesis? This is because germinal matrix is highly vascular. If you look at the morphology of vessels, their lumen is bigger. So now, if you take a retina and throw some VEGF, there's a lot of vessels. But to tell you the truth, like I was not that smart to think about angiogenesis in germinal matrix, and it was a chance discovery. One of my postdocs, she was running a Western blot on VEGF, comparing germinal matrix, white matter, and cortex for the expression of VEGF. It was kind of fishing experiment, and we found that VEGF, vascular endothelial growth factor, was more in germinal matrix than cortex and white matter. So this was just a chance discovery, and I hope I'll show you the blot. Now, look at this picture. This is again human tissues, 20-week fetus. And this is a triple labeling. All red is endothelium. PCAM1 is the marker, and all blue is Ki67. When red and blue, they overlap, it means endothelial is proliferating. So you see that endothelial proliferates. Here you can see endothelial proliferating in germinal matrix. And here, like this picture simply shows that this Ki67 is embedded inside the cell. So you can see from the side view, it is not just an overlap. Now look at this in cortex. In cortex, the vessels, they do not proliferate because Ki67 and blood vessel marker PCAM1, they do not overlap. So we quantified endothelial proliferation index, and we found that endothelial proliferation index was relatively, rather significantly high in germinal matrix compared to cortex and white matter for 16 to 22 week fetuses, and also for premature infants 23 to 35 weeks. Now look at this blot. This blot was run by Homin. She was my, like a technician. She was a doctor in China, and she was working in my lab. So this is a blot, 16 week, 17 week, 19 week, 23 week, and I have tissues taken from the cortex, white matter, germinal matrix. GM is germinal matrix, and you see that every third band is germinal matrix is bigger. Every third band is bigger, which means that vascular endothelial growth factor is more expressed. Its expression is higher in germinal matrix compared to white cortex and white matter. So this is the chance observation that we found that VEGF level is increased in the germinal matrix compared to cortex and white matter. Then we started looking for VEGF mRNA. So we did real-time PCR, and we found that even VEGF mRNA was more in germinal matrix compared to cortex and white matter. And we also discovered that angiopoietin 2 is increased. So angiopoietin 2 and VEGF, they work hand in hand to promote angiogenesis in germinal matrix. So, now I'll skip these. So conclusion of the work was that there's a rapid angiogenesis in the germinal matrix, high VEGF and angiopoietin 2 in the germinal matrix. So next question, if we suppress VEGF, does it reduce IVH? Yes, it does. So how did I test it? I tested it in my rabbit model. So rabbit pregnancy is 32 days. We deliver preemie rabbits at E29. We give them glycerol at 2 hours age, which increases serum osmolarity and causes bleed in the brain in a matter of several hours. So we because we discovered rapid angiogenesis, I was very excited. Can we suppress angiogenesis? So we started talking to AstraZeneca to give us VEGF receptor blockers, ZD6474. They took 6 months to give it. And then in the meantime, I got some celecoxib. My wife is an internist. She had some samples and she gave me celecoxib. We found in the literature that celecoxib, Celebrex, decreases VEGF and angiopoietin 2 in the endothelium. It reduces neovascularization, and it does penetrate the blood-brain barrier. So this is how we designed the experiment. We bought pregnant rabbits and treated them on E26, pregnancy day 26, 27, 28, with oral celecoxib. We gavage fed them, or oral ZD6474 or no treatment. And then do C-section after completion of 3 days course and deliver the pups. Give them glycerol, challenge them, and look at the hemorrhage. And we found, so this is no hemorrhage, this is hemorrhage, and this is severe hemorrhage. This is on coronal section through the cerebral cortex, and this is microscopic hemorrhage. And we found that ZD6474, VEGF receptor blocker, and celecoxib reduced intraventricular hemorrhage. But suppressing, so okay, then we tried to find out how does celecoxib work. And we discovered that celecoxib reduces VEGF mRNA. It reduces angiopoietin 2. 1 second. So VEGF RNA was reduced by giving celecoxib, and angiopoietin 2 was also reduced, and the vascular proliferation was reduced. So this work was published in Nature Medicine. And this was a cover page article. You can see brain hemorrhage in premature infants. And this is a picture of germinal matrix, which we gave them for cover picture. And so the conclusion is that angiogenic inhibition by COX-2 inhibitor or VEGF-R2 inhibitor reduced IVH. Now, after that, I tried to sell it to NIH for a grant that I want to suppress angiogenesis. But people felt that suppressing angiogenesis is not a good idea because you are going to retard the brain growth. Okay. So now I will tell you about why there is rapid angiogenesis in germinal matrix. Because nature is, we always say that nature is perfect. There must be a reason why God made rapid angiogenesis in the germinal matrix. So I started looking at oxygen level in the germinal matrix, and we found the germinal matrix is relatively hypoxic. So this is like a HIF, and like we bought hypoxy probe TM kit from Chemicon, which is Normally-Pour Sigma, and there we injected in the animal, and you can, if you are interested, you can look at this kit. At this increased fluorescence shows that germinal matrix relatively hypoxic. Then we did Western blot on HIF1. Still, I have the data. I never published it, that HIF1 is increased in the germinal matrix. So then finally this concept came. Germinal matrix is hypoxic. Why germinal matrix is hypoxic? Because germinal matrix is home to glial and neuronal progenitor cells. They proliferate. And these proliferating cells, they consume a lot of oxygen. Their metabolism is high. They're mitotic. And that is why, because of consumption, the oxygen drops. And hypoxia, whenever there's a hypoxia, there is more VEGF, more angiopoietin 2, more angiogenesis. And angiogenic vessels, they lack pericyte because pericytes are not recruited here. Astrocytes, they are still forming, and GFAP is not yet developed, and there's a low transforming growth factor beta. There's also low fibronectin. So this also we published several years back in human tissues. So this is why the germinal matrix is fragile. So the angiogenesis story put all my work together, that pericytes, why pericytes are few, why GFAP is not there, everything we can put together in one story. And here is the story. This is story first I published in 2010 in Pediatric Research Review article. Now I have another, it seems 5-6 minutes. So we wanted to know how glucocorticoid reduces IVH. Well, as a neonatologist, if you ask me, what is the best way to reduce IVH? It is prenatal corticosteroid. Prenatal corticosteroid does not simply reduce the incidence of respiratory distress syndrome, but also reduces intraventricular hemorrhage. So what is the mechanism? So we started working on this, and so this is about NIH consensus. So our hypothesis is that prenatal corticosteroid suppresses angiogenesis by downregulation of VEGF and angiopoietin 2 and pericyte recruitment. So we did this work in 2010, and so we gave betamethasone to the pregnant rabbit, day 27, day 28, and then we compared not the mother rabbit. We gave the treatment to the mother rabbit, but we looked at the baby, at the kits, rabbit kits, the baby rabbits, and we compared the premature rabbits which are exposed to betamethasone and which they do not. And I also had human tissues, and we compared the babies who died in NICU and those who were exposed to betamethasone and those who were not. And we found that both in rabbit and human, glucocorticoid, you see, suppresses endothelial proliferation. So the way glucocorticoid works, it suppresses angiogenesis. It suppresses angiogenesis by reducing endothelial proliferation. And in human, this was rabbit data, and this is human data, both in, and this was true both in human and rabbit. And this was, then we looked at the blood vessel density. So blood vessel density was also reduced by giving betamethasone. There is some reduction, not a whole lot, but there was reduced vessel density. So what corticosteroid does, it prunes, it removes the angiogenic vessels, the new vessels, the vessels which are just formed and they lack pericytes, they are immature. And this is consistent with the literature that for the survival of angiogenic vessel or the nascent vessels which lack pericytes, VEGF is important. So vessel density was reduced also in human in the germinal matrix in the babies who were exposed to corticosteroid. And look at the VEGF level. By giving betamethasone, VEGF level is almost wiped out. Then we started looking at pericytes, and pericyte count was also reduced after pericytes count was increased after giving betamethasone in rabbits. So you can see glucocorticoids, you see beautiful green, all green is pericyte, all red is endothelium. So in control, you see that cover, the green is much less. Pericytes are not totally covering, but giving corticosteroid, it increases coverage of pericyte. So corticosteroid stabilizes the blood vessel by suppressing angiogenesis. So, but corticosteroid also has some undesirable effect. It promotes apoptosis, neuronal degeneration, gliosis, and growth retardation. This is we found in rabbits, but when we started looking at human, we did not see much changes in apoptosis and neuronal degeneration. But in rabbits, we did see more apoptosis by giving betamethasone. So conclusion, prenatal glucocorticoid suppresses VEGF and it increases transforming growth factor beta level. It trims the neovasculature and enhances pericyte coverage. These changes stabilize the germinal matrix vasculature, thereby reducing the propensity of hemorrhage. So this is my team. This was my team in 2010 at New York Medical College. She's Furong. She was the one who did all immunochemistry. He's a neonatal fellow. Krishna, he's now associate professor somewhere in Midwest. And she is Caroline Chua, and she is in Florida. She's the director of NICU. He just, Dr. Zia and Govind, they're still at New York Medical College. Thank you very much.
Well, thank you so much, Praveen, for taking us on this journey, which really was a journey of 25 years almost. Very, very interesting, excellent presentation and helping us to understand why these premies are getting their IVH so easily. Thank you really very much.
Thank you, thank you.
Thank you so much from my side too. Fantastic trip together, and thanks to you. And it's not only looking at what we've done over the last few years, but where we may go and why few things may work that already we know. So thank you so much.
You're welcome. Thank you.
Right. Linda, we have to also to thank Professor Ola Saugstad that has joined us, and he's the chief of the committee of the WEMPS. Good afternoon, Ola. Good afternoon to you, and good morning to Praveen.
Yeah, sure.
So we are here and we got few questions. Linda, should we go?
Yeah. So I can see the questions in the chat box.
Yeah.
So I can read the questions.
Well, up to you.
Right. Yeah. So that the first question is, I had a preterm 27-weeker with platelet of 7,000. Despite this, thanks God, no germinal matrix hemorrhage. So to answer this question, platelets are very important, and we see that low platelets, they bleed. So first of all, what was the postnatal age of the infant? because after 72 hours anyway, they become immune. And IVH is a multifactorial disorder. We do not know, about what was going on in the germinal matrix related to the fragility and fluctuation in the blood flow. So we see all the time that, sometimes platelets are low, still they don't bleed. Was the baby Iugr? A lot of times we see that Iugr babies, they do not bleed. Perhaps because of stress, they have less angiogenesis. So what could be the protective mechanism? So protective mechanism, I can say that the baby was perhaps not having much fluctuation in the blood flow, and blood-brain barrier was stronger. Maybe baby was Iugr, got 2 doses of prenatal corticosteroid, possible. Then should I go with next question or?
Yes, please.
Yes. What if we give just 1 dose of celecoxib? Can it inhibit proliferation for a long time? So, celecoxib, which is selective COX-2 inhibitor, isn't it? Whereas, when we use indomethacin, it affects COX-1, COX-2 both. And studies have also shown that places where, wherever we use indomethacin, IVH is less. However, long-term outcome is not much different except in males. This was the work done at Yale University. Now, how much 1 dose of celecoxib will work, I do not know, but I wanted to do this work, but this was very hard, giving 1 dose of celecoxib in human, because celecoxib, there is a warning on celecoxib that, it perhaps can increase the risk of ischemic heart disease, celecoxib. That is why, it is not being that commonly used. But advantage of celecoxib is that it can be used in preterm labor and it will reduce preterm labor. But celecoxib never become popular. Maybe that we can give second thought of using celecoxib, but because of that warning, I think that celecoxib. But anyway, people are using indomethacin. Now, whether it will inhibit proliferation, now proliferation is more histological question. We can look at in the animal model and human, they are not always the same, and effect is always dose dependent. I'm not sure 1 dose, 2 dose, what milligram, how many milligram per kg. So these questions are, very difficult to answer. Now, going to third question. Is there any different effect of preterm cerebral vasculature between different kinds of antenatal steroid therapy? We use dexamethasone as antenatal steroid in our country. So prenatal corticosteroid, which is good, betamethasone or dexamethasone with respect to IVH? In general, dexamethasone versus betamethasone, both of them has pros and cons, and people, they use dexamethasone and betamethasone equally, and there is no major advantage or disadvantage of one over another. This is my knowledge. Many of you in the audience can better answer this question, but which is good for antenatal steroid therapy, I do not know the answer. But some people believe that perhaps betamethasone penetrates the blood-brain barrier better compared to dexamethasone. But this is, these are some long time back experiment done in animal model. What happens to human is unclear. Now, next question is, what is the effect of different level of oxygen brain concentration to angiogenesis in germinal matrix? Or do we have any data about it? Do we have to rethink about oxygen target in the brain? See, the oxygen level in utero, if whatever we teach, what we teach our residents, that oxygen, that PO2 level, once baby is born, is about 50, 60 in NICU, isn't it? 50 to 60 millimeter mercury. And then cerebral oxygen is about 23, but no one knows what is oxygen concentration in germinal matrix. But what we know that I'm sorry, like I'm trying to get confused. Yes, in utero, in fetal circulation, PO2 level is about 23 millimeter of mercury. When babies are born, it rises from 23 to 60. So oxygen level after birth increases. And as oxygen level after birth increases, it will suppress angiogenesis. There's no data that if you give 100% oxygen, 20% oxygen, or 30% oxygen, how it is going to affect angiogenesis in humans or in animal model. Or there may be, I'm not aware. Now, then, have you done any work on the effect of mag sulf on brain vasculature? You know, like I have not done any work, but as much as I know that the way magnesium sulfate works, it blocks the NMDA receptors. Magnesium virtually sits in the NMDA receptor and does not let calcium enter inside the cell. And how does it affect the vasculature? I'm not aware. Is there any evidence of beta-methasone can exacerbate PVL? So how beta-methasone will make PVL worse? So interesting questions, and there's a lot in the literature on corticosteroid and corticosteroid and oligodendrocyte, and effect is dose dependent, duration dependent, and timing dependent. You know, like a long time back, Dr. Andrew Whitelaw, he wrote a review article, but in general, the effect of beta-methasone is dose dependent, timing dependent, and context dependent. And prenatal corticosteroid, we again started, we use it all the time in our NICU when our babies have increasing oxygen concentration and mostly in the fourth week of life. Do you think if extremely low birth weight infant who after born has IVH, who would get anti-VEGF? Once IVH has developed, there is no point giving anti-VEGF. And you know, like anti-VEGF rather will suppress angiogenesis. So, you know, so preventing IVH is more like, because most of the IVH happen in first 3 days. So if someone has to target reducing IVH, the best bet is prenatal or immediately after birth. But suppose we target immediately after birth, babies are born and we give them corticosteroid. You know, like by the time because if we think that if we give corticosteroid after birth immediately, you know, it takes time for suppressing angiogenesis. It is not 1 to 3. So prenatal approach, to my mind, is better compared to postnatal approach in preventing IVH. But these are all my answers are my, you know, like are my thoughts, and I may be incorrect and I stand for correction. I must be truthful. What is your opinion about use of physiological dose of hydrocortisone on first day of life and influence germinal matrix? So this question, I answered that hydrocortisone, if we give immediately, it will take time for angiogenesis to be suppressed, and we may lose the window, first 3 days window, because anyway after 2 to 3 days, the vessels, they mature and they do not bleed. How about oxygen? Does it play a role in affecting angiogenesis? And could it play a role during labor? So oxygen stimulates angiogenesis. This is well known. Hypoxia triggers increased production of hypoxia inhibiting factor HIF1, and which promotes angiogenesis. And angiogenesis is important for brain growth. You know, like just like neurogenesis is important for brain growth, angiogenesis is important, because if blood vessels are not there, how the neurons will get oxygen and all the substrate for their metabolism and growth. So suppressing angiogenesis doesn't seem to be the best idea, but we have to weigh between, like when we do treatment, then we look at risk benefit. We give prenatal corticosteroid, we reduce IVH. And it may be good to suppress angiogenesis briefly rather than getting grade 3-4 IVH and damaging the brain. So that is why the corticosteroid is being accepted worldwide. Prenatal corticosteroid is the standard of care. So using oxygen, like once babies are born, we cannot give them low oxygen, because we have seen from previous clinical trial that when we target 85% oxygen, then there is more mortality. When we target 95% more oxygen, we have more ROP. So perhaps best way to go is 90 to 95% oxygen based on our previous clinical trial. What happens with germinal matrix postnatally? So germinal matrix gradually reduces in size. And as I said, that by 38, 39, 40 weeks, germinal matrix disappears because there's no need of germinal matrix. Whole brain is formed. All 6 layers of cortex, neurons, oligodendrocyte, astrocytes, everything originates from the germinal matrix. What do you think? Indomethacin ibuprofen reduces IVH by reducing VEGF? I do think that indomethacin, I'm not sure about that this might be reducing VEGF, but is there any evidence? Have I done an experiment? No, I have not done any experiment. Only experiment which I have done is that corticosteroid reduces VEGF, postnatal corticosteroid. I have not done these experiments. There are many QI projects with aim to reduce the rates of IVH. They have been particularly effective in reducing rates of IVH. Which intervention beside anti-inflammatory steroid and Maxulp should be included in our quality assurance program? Like I'm not sure how much magnesium sulfate reduces IVH. Perhaps it does not. Prenatal corticosteroid is the best strategy to reduce IVH. Other than corticosteroid, I don't have any strategy to suggest.
And Praveen,
Praveen, can we help you summarize few questions? Otherwise, if we answer one to one, in the meanwhile, they are booming. So
right, sure, I will happy. Yeah, I'll happy to go the way. Yeah.
Yeah, so there are quite few people asking in your way, in your like Anita treatment, in your also hospital, what's your bundle, what's your idea in order to try from I guess a clinical point of view to reduce the severity of IVH? Any sort of secret that you're not spreading yet?
Well, like I don't have any secret, like I do not do anything different, just prenatal corticosteroid. That is the only thing which I know and which we do it. I wish I can publish it, like something. This is a great question that, like, can we reduce IVH?
But,
like,
when someone like you is speaking in front of so many people, we are waiting for a secret. You have to pretend to have a secret. Just
right.
to,
sure. Yeah.
So happy to say go in this direction. They're asking as well someone about EPO. Someone is asking why Iugr, and I think it's an interesting question because when you were mentioning Pericyte's job in the germinal matrix vasculature, Iugr may have some sort of potential, how to say, hypothetical reason for being not so good for the tight junction. Any clue on the...
like what I believe that Iugr babies are stressed out. Maybe they have higher level of corticosteroid, and that is why their angiogenesis is relatively like less. So less angiogenesis.
Despite the white matter may be, how to say, reduce in strengthness.
Right, right. So if you know, like there's less angiogenesis, then there is less fragility. So
And there was also another question that I was very happy to. Sorry, Linda, because I mean, we need to participate. I don't want to overtake you. Sorry for that. Sounds a bit unfair for a lady. But anyhow, what's about the fact that the germinal matrix vasculature probably is not so any more vulnerable after 3-4 days of life? What do you think about that? Is oxygenation simply or hyperoxygenation?
This is not proven, but you know, like when I wrote my Nature Medicine paper, then I did speculate that once babies are born, PO2 level rises. In utero level is 23, 24. PO2 level goes to 60, 65, and this suppresses angiogenesis because for hypoxia triggers angiogenesis and high oxygen level suppresses angiogenesis. We have not to put the babies on high oxygen to suppress angiogenesis. And maybe, you know, like as much as I know.
Well,
now,
should I remind you that we have Ola Saugstad listening that I think 30 years ago, or even more, was saying, be careful with oxygen, Ola. So we're still there discussing as if at that time he was a pioneer. I think we can guarantee, Linda, what can you say? He was pretty alone in this sort of mission, no? But we're still discussing that kind of things when you are jumped from in utero to ex utero. But the fact that IVH is not anymore there as a very high risk after 3-4 days, I think is pretty a shared conviction in between us. So we have to look for an explanation.
Right. Thank you. I was thinking when you were asked about the oxygenation concentration, and as far as I know, there's no data really about FiO2 during, for instance, resuscitation and IVH. But when you look at some of the randomized studies in premature babies with low and high oxygen FiO2s, as far as I remember, there's no difference in the outcome regarding intraventricular hemorrhage. So that's the only data I know about.
Right, yeah.
As I can remember.
Right. So only thing I can say that IVH is a multifactorial disorder. It is angiogenesis is one thing, but it is also fluctuation in the blood flow. Babies who are relatively sick and unstable, they have more fluctuation in the blood flow. And you know, like so babies who are unstable, they have more chances of IVH. This we see it. So now but in general, you know, like babies are immune to IVH after first 3 days, and my belief it is because of suppression of angiogenesis. But you know, like but further work is needed to really clarify that why after 72 hours maybe they do not bleed. I totally agree to that fact. And I'm happy you brought out this point.
Yeah, Praveen, I mean, it's true that you see most of the hemorrhage during the first 72 hours, but sometimes they can still occur or expand a little bit after the first 72 hours. So it's more or less, but unfortunately, we do see it sometimes occur a little bit later as well.
Yeah, 90% they bleed in first 3 days, 90%, 10% later. Maybe on day 4, there's a big pneumothorax and they bleed.
Yeah.
So, but this is like very clear cut that first 3 days, 90%, a big number. So they become not immune, but they become relatively immune to IVH after 72 hours. Yeah. So this is what I'm trying to emphasize. I do not disagree to the fact that they can bleed on day 5. Of course they can. But what is more common is first 3 days.
Yes, definitely. Luca, what do you think?
About the multifactorial aspect of the IVH, I believe is still there. And I believe that if you have a stronger factor, like you were mentioning, a pneumothorax later on, or even a sepsis or whatever, you may have a bleed later on. I'm still totally really in love with the hypothesis, especially because when you read the famous papers, quite few Praveen has mentioned on pathology, they really struggled a lot to see the reason of the hemorrhage coming from the vein. Someone was happy about that. Someone was suggesting is an arterial. Someone else was suggesting it's difficult to say. So my opinion is that maybe things have changed, and the IVH of 25 years ago was mainly due to our reduced skills of ventilating babies and the fluctuation from Jeffrey Perlman when he was showing that Doppler paper was really fascinating at that time, no? Right. Because we were all convinced that it was the potentially most important factor, but nowadays probably less than at that time. So right. The medicine is changing. And yesterday, Praveen, we were worrying about even the way we treat these babies, and we were happy that we ventilate babies better, but we need to also to, in my opinion, have an optimum approach to the stability in the first 3-4 days of life. So I think still from a clinical point of view and from common sense and from great research such as you're doing, it's still a very fascinating subject, because it's still the most common lesion in the brain of a PREMS. And we look at that. We managed to have PVL almost disappeared. And if I'm asking you 5 experts in the world, they may reply in 5 different ways why we managed to do that. Medicine is fascinating with the mysteries, and like your talk that is giving us insights in this extremely very nice area of the vessels, and understanding how the vessels are affected by hormones, neurotransmitters, fascinating. And still the flow. Okay, blood flow is still important.
Well, thank you so much, Praveen.
Yeah, thank you. Thank you for inviting. I really enjoyed.
For another hour. Thank you.
Yeah, we may go on for a couple of hours discussing that. Right. But we have a next step, and Praveen, if you're still happy to wake you up early, we have Terry